Good morning, everybody. So we'll be starting our instruction course 84 right away. The title Nuances in Ophthalmic Pathology. Our first speaker is Dr. Somashila Murthy. Dr. Somashila Murthy is medical director at Shantilal Sangvi Hospital at Mumbai, and which is a collaborative institute of L.B. Prasad Eye Institute, and she is also a member of scientific committee AIOS. She has did her fellowship in cornea as well as trained under Professor Rao at Doheny Eye Institute. She has over 200 publications to her credit. She will be speaking on infectious and immunological scleritis case-based study. Dr. Somashila.
Thank you very much, Dr. Deepankar Das, and it's a pleasure to be part of this symposium. And I'm so delighted to see that we have, apart from both you and Dr. JB, we have true blue pathologists also attending. I'm a pseudo-pathologist, as Soumya knows. Can you please put up my presentation? So I thought I'll restrict to, except for one slide on what we are supposed to see in immune-mediated scleritis, Deepankar, I thought I'll restrict to infectious, because Soumya didn't send me the slides for immune-mediated. I'm lying. No, because we don't have, so in other words, for immune-mediated, we don't really take too many biopsies. So I went through my library of cases and I couldn't really see a case where I'd sent for a biopsy, but it turned out to be purely immune-mediated. So that's why, apart from a slight discussion, I'm going to go to infectious, which is very interesting also. I'm sure Dr. JB will be interested to see the pathology in these diseases. So clinicopathological of infectious, mostly scleritis, which is case-based. Very quickly, this is what I wanted to say about pathology in scleritis. So we know that pathology in scleritis is actually infrequently employed. Unlike, say, for me, it's corneal tissue. You really need the histopathology to figure out what's happening. And many other aspects of the eye, we need pathology. So, however, in the scleral tissue, it's because how much can we biopsy? So we take very small fragments of tissue and then we expect the pathologist to do some miracle from it and bring out the diagnosis. That is kind of hard. And then most of the cases of scleritis can be either an isolated immune-mediated disorder, or they can be associated with systemic autoimmune disease. If it's systemic autoimmune disease, sometimes the answer is in front of us. So say RA or GPA and so on. So we don't really look at pathology from sclera. So the most important role for me as a clinician when I want to perform a scleral biopsy is when I have conditions which mimic immune-mediated scleritis, for example, infection, and the rarer neoplasm as well. And second is, even though I know it's infectious scleritis, but oftentimes we know that we have to take multiple scrapings from microbiology in order to get to the diagnosis. And this is the second very important role of pathology, where it can help us because pathology can pick up, say, fungal filaments very easily, even from scleral tissues. So it's always a confusion whether our scleritis is autoimmune or a masquerade or infection. The pathology in scleritis has been classified in an earlier paper by Professor Narsingh Rao and his group, where they had taken the autopsies of over 50 eyeballs of patients who had enucleation done for scleritis, and then they looked at it, and then the other group wrote a review on it, which I'm quoting here, and they divided pathology in scleritis as either systemic immune-mediated, in which case, if you see the sclera under the microscope, you're likely to see varying mixtures of palisading granulomas, necrosis, and vasculitis. Whereas in the case of infection, you're going to see obviously a lot of acute inflammation and sort of devastating necrosis in the tissues. And in the case of an idiopathic immune-mediated scleritis, they have mentioned that you will be more likely to see chronic non-specific inflammation with either follicles and various amount of fibrosis, because it's very chronic condition in these cases. So that is what you're likely to see in the pathology of scleritis. Coming straight away to the case-based part of my talk, my first case is a 55-year-old man. He had injury while chopping wood, and when he came to us, you could see in the slides here, you can see that he has a very diffuse, angry-looking eye, and somewhere here is a nodule. Not very sure. So what we did is, he had secondary glaucoma. The B scan showed shallow choroidals. So while we had to explore to see where exactly is a penetrating injury, and we took microbiological scrapings. Very soon on follow-up, the patient then started developing necrosis in this area actually, and not in the what we thought was a nodule inferiorly. The first microbiology culture was doubtful, but it came as Corynebacterium. We started the patient on antibiotics. Patient is just not improving. And subsequently, we saw that the patient then presented with abscess-like looking like a draining sinus-like lesion here, which on a subsequent, the antibiotics are still continued, subsequent visit it worsened. And at this point, when we took material from here, luckily for us, this was the third scraping that both the microbiology showed fungal filaments, and by this time we got more sort of smart, and we sent a lot of tissue to the pathology clinic department as well, and they could isolate this nice big fat fungal filaments which are happily growing in there. So luckily, once we got the diagnosis of fungus from microbiology and pathology, we could start the patient on antifungals, and we had a remarkable resolution for this patient. The second case I have is slightly different scleritis, where you have scleritis with uveitis, and even the cornea was involved. So this was like a sclerokeratouveitis. The main focus is this nodule sitting, straddling the limbus, as well as going over to the cornea. In fact, the peripheral cornea had thinned out so much that there was a communication from the anterior chamber into this nodule, and the pupil, if you are able to see, is slightly peaked for that reason. So this obviously was looking very, not at all like immune mediated. This is not look at the surrounding tissue, doesn't even look that angry. So for us, the top diagnosis we had was infection. And if we examined the patient systemically, we could see that he had depressed nasal bridge, he had thickened ear pinna as well, and this very dry appearance. He also had some trophic ulcers. So this was, we were dealing with a patient with Hansen's, and since we also had to repair the tissue because it was communicating with the anterior chamber, so we had planned for excision biopsy with a patch graft. This is what the patient underwent, and what you can see is this chronic inflammation, and when we go to the special stains, he was steaming with Mycobacterium leprae in that nodule. Patient also had slit skin biopsy from the skin, the ear pinna, and that also showed leprae bacilli, and the patient was started on Hansen's treatment, but he kept on defaulting to the treatment and ultimately was lost to follow-up. The third case I had to discuss is a case of, this is very interesting case, presented as what we thought was necrotizing scleritis with PUK. This is a young male patient, and our top diagnosis for necrotizing scleritis with peripheral ulcerative keratitis was sort of a systemic vasculitis, especially GPA. So we investigated the patient more than once. We did all the serological tests, ANCA 2-3 times, maybe sent the patient to rheumatologist. The patient had also undergone excision biopsy a couple of times, in which the only report was non-specific inflammatory cells. So this is not the first visit pictures, but the pictures when he came, when he already had perforation because of the chronic PUK. And so we have blinders. When we look at scleritis, we think it's only scleritis. But what now we see in retrospect is that this area looks very white actually, and there's some kind of plaque here. So those are the clues. And there was a nodular component as well to that area of peripheral thinning and the white plaques over here. So the patient was on high dose of steroids, whether it's topical, oral, and also immunomodulators, but nothing would improve the patient. Finally, the PUK just kept on progressing, and this is the nodule, which now looks like a very dense white plaque. And by this time, we knew we were dealing with something else, and the oncology colleagues stepped in. By this time, they knew that we are not at all dealing with scleritis, and the only option for this patient was evisceration. During evisceration, in fact, there was extensive bleeding, and the choroid was firmly adherent to the sclera. And so the final diagnosis, based on histopathology, I need not take any guesses also, is that this was a case of invasive OSSN. You can see that such proliferation of the tissues. So if this is the coats of the sclera, so the OSSN was invading deep into the eye, as well as these squamous pearls that you see typical, as well as a lot of inflammation even along the uvea. So in the earlier part of the disease, that the patient did have a lot of inflammation, which kind of put us off track. But the keratic plaques, as the patient kept on falling up, was the final clue. So this is too late to resuscitate the patient. This is in a nutshell what we saw for the patient. Coming to another case of quote-unquote necrotizing scleritis. By this time, all of you non-pathologists also have realized that we're not on the track of necrotizing. 56-year-old man, 3 months history, and drop in vision comes to us. and already came with investigations as well as microbiology workup because there was these nodules which looked like yellowish and more than one. So the top diagnosis was infectious scleritis for this patient, and one of the nodules also underwent biopsy, which no organisms came from that. And we thought that this bare area is where partly the biopsy was done, and the patient had been receiving antibiotics as well as oral steroids, and there was no improvement. So by the time we saw the patient, we also couldn't figure out because the clinical picture was masked. And the first thing, one of us went ahead and repeated the scleral biopsy, which showed a lot of chronic inflammation. Maybe the amount of tissue was not representative, or Oz was very small. So as the patient followed up, the same story, that the patient didn't improve at all. Maybe 2 or 3 weeks later, we saw this picture where that area where we took the biopsy from was very quickly getting extensively fibrosed and not looking healthy. Once again, our oncology colleagues were also seeing the case with us, and they diagnosed the patient to have a sort of a nodular ulcerative variant of OSSN. And the CT scan, you can see that there is thickening. It's involving the coat of the eye from that side, and therefore this patient also had to undergo exenteration. And you can see this beautiful specimen, well, beautiful for us, but not for the patient or anyone else, where the tumor had invaded into the coats of the eye as well, so causing compression. So this was a diffuse OSSN with orbital invasion, and the patient had to undergo exenteration. Coming to probably my last case is a case of scleritis with granulomatous uveitis. Whenever we have a patient with granulomatous uveitis along with scleritis, then it's different from the routine infection also. We know that there's a high chance of infection if you see, say, hypopion and very prolific anterior segment inflammation. So for me, I've always felt that these cases represent very severe or very chronic inflammation. So this patient did not give any history of trauma, and by the time he presented to us, he had secondary glaucoma. So we did an AC tab and scleral biopsy. I don't have the initial pictures, but pretty much post biopsy, this is what the patient looked like with that. So the histopathology actually revealed gram variable bacilli, which are acid fast and beaded. This was like tissues that showed chronic inflammation with epithelioid and giant cells, and we could also isolate more bacilli. So finally, the diagnosis was atypical mycobacterium. Unfortunately, this patient did not have a great outcome, had extension of the infection despite our best efforts.
So Marshila,
So
can
that's
you
it
conclude?
in a nutshell. And this is our new team at Shantilal Sangvi, where Dr. Dipankar is so kind to introduce, and these are my colleagues who work with me. So we see scleritis as an infection. Everybody else scratches their brains, but I am the gleam in my eye. Hopefully the patient doesn't see that, but I get very happy when I see those cases. Then it's so satisfying to treat them, thanks to microbiology and histopathology. Thank you very much, Dipankar.
Great and challenging cases, Somashila. Just a quick question: whether you see infection sometimes in the tumor OSSN or a combination of immunologic versus infections? Can you see in a combined way?
Yes, the second one definitely, because we have, even Dr. JB sir has published. So we have patients with chronic RA presenting to us with initially with, say, necrotizing scleritis, and that gets secondarily infected. And that has not happened once, but I've seen more than maybe 5 to 6 such patients. And the second is infection on tumor, though I have not seen a patient with us. Luckily, the tumor missed as scleritis is very, very rare. So these are the only 2 cases in my career that we were co-managing. But the other side, the other entity of getting an infection secondary on immune-mediated, I think that will happen, and we have to keep looking out for those cases.
Thank you, Dr. Somashila. Now I invite Professor Jyotirmoy Biswas to deliver his talk on stromal choroiditis, a case-based presentation. We are running a bit short because of the previous session. Professor Biswas does not read any introduction. He's a further figure in ophthalmic pathology and uveitis. Has more than 500 publications to his credit, and is the person who first described the HIV ophthalmic manifestation of HIV infection from the country. Okay, and lot of his research involving TB, particularly the enucleated eyeball. Professor Biswas.
So, good afternoon, and thanks Dipankar for including me in this exciting instruction course. I just like to tell about that Somashila, that one. We have seen syphilis presenting as a nodular scleritis, and that is also one should keep in mind. So, I'll be talking on stromal choroiditis. The stromal choroiditis is not rare. The common cause is sympathetic ophthalmia, Vogt-Koenige Harder disease, tubercular choroiditis, sarcoid positive uveitis. Unfortunately, we don't have the pathology specimens of except sympathetic ophthalmia in many of these entities. So we don't know the pathophysiology or pathologic correlation. So sympathetic ophthalmia, as you know, rare bilateral granulomatous panuveitis. Exciting eye is following surgical or accidental trauma to one eye. Sympathizing eye is the uninjured eye developing uveitis after a variable latent period 5 to 60 years. And here is an example of sympathetic ophthalmia. You can see that multiple choroidal nodules are seen, and there is an optic disc also has nodules. And what we see in pathology is a diffuse granulomatous uveal involvement with lymphocytes, epithelial cells, giant cells, and occasional eosinophils. Eosinophils are present in the early course of the disease. Relative lack of retinal inflammation. You don't see retinal inflammation in sympathetic ophthalmia. Absence of inflammatory reaction in the choriocapillaries. Early enucleated eyes demonstrate a sparing of the choriocapillaries. We can see the Dallen-Fuchs nodule. Granulomatous process may extend to the scleral canal and optic nerve. Here is the example of Dallen-Fuchs nodule clinically on fundus photography, and here is one of the histopathologic example of cut section of the globe showing diffuse thickening of the choroid. And here is the Dallen-Fuchs nodule. You can see the RP is elevated. Underneath the RP, the choroidal granuloma is seen, and the choroid is diffusely infiltrated with inflammatory cells comprising of the lymphocytes, and there is a collection of epithelial cells are seen as a form of granuloma. And there is a whole section, whole eye images of a sympathetic ophthalmia. You can see superiorly there is a perforation of the globe, and there is a diffuse thickening of the choroid, and there is a sensory retinal detachment. And here is the histopathologic examination of the thickening of the choroid, and you can see that granuloma is seen underneath the RP, epithelial cells, and lymphocytes, and there is a diffuse collections of the lymphocytic infiltration, and choriocapillaries is remaining uninvolved. So in case of Vogt-Koenige Harder disease, specimen is hard to get, and you can see that some Dallen-Fuchs like nodules in the periphery, and this is in the left eye. And here you can see the diffuse infiltration of the lymphocytes, and there is a granuloma also, as we see in case of sympathetic ophthalmia. And here is the case of big age where the retina is not involved much, and there is a secondary changes in the retina, and there is a diffuse infiltration of the lymphocytes in the choroid. We described clinical pathological and immunohistochemical correlation in the case of BKH with Dipankar, and this is a case where immunohistochemical study was done in Dipankar's lab, and you can see that the diffuse infiltration of the lymphocyte seen in the choroid, and this is a higher magnification, and you could see that there is a CD3 predominantly involved, and few B cells were also seen, CD20 B cells. So shifting gear from the non-infectious uveitis to the infectious uveitis, tuberculosis, way back about 40 years back, we have got a patient who had a multiple subretinal abscess. We thought that this could be due to sarcoidosis because the squam test was positive and serum ACE was elevated. But the patient did not respond to the steroid, worsened, and then even he started of the antitubercular treatment. They didn't lead to panophthalmitis. The eye was to be eviscerated, and the eviscerated globe, to our surprise, showed myriads of acid-pass bacilli in the retina, within the retina and the subretinal space. There is an article by Dr. Professor Narsingh Rao has described tubercular uveitis, described the presence of mycobacterium tuberculosis in the retinal pigment epithelium. Here you can see the retinal pigment epithelium is necrotic, and within the necrotic retinal tissues, we could see that multiple acid-fast bacilli. So it is possible the direct infection of the tubercle bacilli can occur in the retinal pigment epithelium in case of multifocal choroiditis due to the tuberculosis. And this is a case of tuberculous serpiginous choroiditis published by Padma Malini and Dr. Narsingh Rao, and the patient has typical fluorescent angiogram picture of serpiginous choroiditis, and OCT findings show subretinal scar, and here is the fundus photography and fluorescent angiogram, autofluorescence, very characteristics of serpiginous choroiditis. This patient had undergone had retinal detachment and undergone retinal biopsy, retinochoroidal biopsy, and the retinochoroidal biopsy showed inflammatory cellular infiltrate, predominantly lymphocytes with epithelial cell granuloma. The giant cells is seen in the picture. I worked on during my fellowship in 1989. 2 patients of AIDS had died of the peculiar choroidal lesions. As you see, there is a choroidal granuloma seen. Both the patients' eyeball was received on autopsy, and autopsy examinations, this is a gross photograph taken by me, showed choroidal infiltrate. This choroidal infiltrate showed acellular eosinophilic material, which on GMS10 showed pneumocystis kinase cyst. In electron microscopy showed typical characteristic pneumocystis kinase cyst with multiple daughter cyst with inside encapsulated material. So this was my first publication as a fellow. There is a recent article in JAMA Ophthalmology 2025, which I want to highlight. This is a parasite, Strongyloides stercoralis. The patient died, and the autopsy of the eye from the choroid, autopsy of the patient's the eye tissues are available, and you can see in the arrow mark there is a parasite sitting over there in the choroid with diffuse infiltration of the inflammatory cells. And this patient was subsequently on high power magnification. Parasite was seen, and this lung also contained the same parasite. So what we are seeing many phases of choroiditis, we are not able to identify and call it as autoimmune, could be due to some infectious organisms, including parasite. So in conclusion, stromal choroiditis is quite common and can be due to non-infectious like autoimmune, VKH, sympathetic ophthalmia, and infectious causes. Histopathologic studies are scanty except in sympathetic ophthalmia, but nowadays with the molecular biologic study and immunohistochemical study, the pathophysiology or pathogenesis of the disease can be elucidated elegantly. Thank you very much for the wonderful.
Thank you, sir, for this wonderful presentation. Any question to sir? So, sir, is there any difference between a Dehlen-Fuchs nodule between sarcoid, VKH, and sympathetic ophthalmia?
Now, this is a VKH, they call is a nummular choroiditis, and then they do have the only lymphocytic infiltrations over that one. So there is a very scanty literature of the VKH cases. Dr. Narsingh Rao did some work in the Japan on VKH patients, and he found what is called Dehlen-Fuchs nodule in VKH is not actual Dehlen-Fuchs nodule, is a nummular infiltrate.
Thank you, sir. Thank you so much. Now I like to invite Professor Rima Bansal to present her clinical pathology cases of viral retinitis. Professor Rima is from PGI Chandigarh, and she is the PhD holder on the basic uveitis research, plus she is the IOSG member, numerous publication, more than 150, and numerous presentation, and she is basically she has done her research on TB, choroiditis, and viral retinitis. Professor Rima.
Very good afternoon. Thank you, Dr. Dipankar, for having me in your instruction course. So my topic is clinical pathology of viral retinitis. It sounds very simple, and I'm sure I'm going to show you simple cases. So this is the first case of a 34-year-old male. I'm not going into literature because I was strictly told it has to be case-based. A 34-year-old male presented in January last year. He was a known HIV positive. He had completed art therapy, and he had both eyes decreased vision, light perception in both the eyes. He was treated elsewhere 1 month ago, and this was the fundus picture, both the eyes. It's very obvious, the diagnosis is a known HIV. So we're obviously dealing with bilateral CMV retinitis. The anterior segment photographs, a bit of endothelial dusting. We really don't see much of reaction in these eyes, but what was surprising was bilateral posterior subtenon deposits. He was treated elsewhere. So he was treated as probably a non-infectious uveitis or a retinitis, I don't know. So this is what exaggerated the disease in his both the eyes, because he had completed his ART. So we treated him with bilateral intravitreal ganciclovir, though under guarded prognosis, because we were not very hopeful of the visual recovery. And we did take an AC tab for CMV virus, and it turned out to be positive. So you can see the amplification curve, very much similar to the positive control. And this is the melting curve, again coinciding with the positive control. So he went on to receive multiple intravitreal ganciclovir injections and also received oral valganciclovir. And this was the baseline presentation, and at least anatomical outcome we could achieve to some extent. And the lesions resolved very fast. So this, we demonstrated the presence of CMV virus in the anterior chamber, but if it had been done timely, the prognosis would have been much better. So this was a case of CMV viral retinitis. Second case was a 69-year-old male. Just look at the age. So this is not the very typical age of presentation of viral retinitis. He presented in March this year, decreased vision in the right eye with pain and redness since 15 days. He gave history of hernia and prostate surgery. He was hypertensive, no other systemic complaints. His HIV TPHA was negative. So this was the clinical picture. His vision was 624 despite so much of vitritis, and you can see multiple tiny discrete retinitis lesions all over in the periphery, along with tongue-shaped lesions of retinitis. So we had both. His IOP was fine. He had KPs, 2+ cells, posterior synecdoche. Corneal sensations were normal. So this was the left eye. It was normal, no complaints, 6/6 vision, but we saw some of these spots in nasal periphery. So they looked inactive. However, we did the OCT through these lesions, and it was just some pigmentation and scars. So the fluorescein revealed vascular leak along with the hypofluorescence along the lesions, and the left eye did not show us anything. So we were sure we are dealing with a clinical diagnosis of acute retinal necrosis in the right eye. Because the age was 69, so we had to think of possible other causes. We did an aqueous tab from the right eye for PCR viral and IL-10, IL-6. VZV was positive, so with the baseline RFT, we started him on IV acyclovir, plenty of fluids and oral prednisolone. And again, you can see this was the PCR curves of the test sample. And this was at 5 days, and this is at 1 month. So he's on follow-up now, shifted to oral acyclovir along with steroids. So this was a case of VZV viral retinitis. So we had this is the third case and my last case, a 47-year-old male, but this is a long case. So 47-year-old male, he had right eye acute retinal necrosis, presented in September 2015, almost 10 years ago. He was HSV positive from the aqueous tab. We treated him with IV acyclovir, oral steroids, and he did fine from September 15 to February 2016, almost 6 months. And in February 16, he came back with the recurrence of vitritis and the tongue-shaped lesion, the previous reactivated lesion. Again, he was in maintenance dose of Valsivir. It was high to 1 gram TID. Oral steroids were restarted, and he kind of did all right till May 2016. He was lost to follow-up in 2017, and he came back in March 2022. So there was loss of follow-up because of the COVID, and we don't know whether COVID had a role because he had already developed a recurrence before COVID. So he comes back in March 2022. His anterior segment picture was almost the same as what we saw at initial visit: corneal opacity, iris atrophy, and this was the vitritis in the same eye, active retinitis lesion. We started him again on IV acyclovir, gave it for 2 weeks with oral steroids. He did fine till September 23, and which again he was put on maintenance dose. And so this was basically the flow: September 2015, 2016, then recurrence in March 2022, and 2023 he was fine on maintenance dose. So this year again we saw him in January. He's a very well educated gentleman from a very good family. He's very much aware of his symptoms, of his treatment, very compliant regarding his treatment. So January this year he came back with the same eye involvement, decreased vision since 2 weeks. Now you can see he had recovered a vision of 6/6 in the left eye. He goes down to counting fingers close to face. You can see severe vitritis, and the same infranasal retinitis lesion had shown reactivation. So this was, we made a diagnosis of recurrence of AN, admitted him IV acyclovir with the baseline RFT. So the expected protocol was the same, but to our surprise, his it's a long thing, but I'll tell you, after 4 doses of, maybe 3 doses of acyclovir, he complained of decreased urine output. He was admitted with us, so everything was easy to manage. His creatinine was high, urea was 80, creatinine 2.5. We stopped IV acyclovir, we started IV fluids, got a nephrology consultation, and this was after 5 doses of IV acyclovir. Now what do? You stop IV acyclovir. So his investigations showed that his creatinine kept on rising despite stopping acyclovir. Urea kept on rising. So this was the sequence: 11 Jan, 12 Jan, 13 Jan, 14 Jan. His creatinine had shot up to 10. Now he was shifted to nephrology ward. It was scary. They diagnosed him probably as acyclovir-induced toxicity leading to rapidly progressive renal failure, or complementary and alternative medications, because he did give history of using some Ayurvedic medications. He was started on hemodialysis, planned for a renal biopsy, which confirmed acyclovir-induced crystalline nephropathy. So because we could not give him acyclovir, the nephrologists tell us that we have to give dose-adjusted antivirals in these patients, and these are the various formulas we resort to based on his creatinine clearance, which was 10 milliliters per minute. So oral steroids were started, and we gave him oral Valgan along with intravitreal ganciclovir because we were desperate to give him antiviral cover. So this was his progress from counting fingers. He improved to counting finger half meter within 4 days after oral and intravitreal Valgan. After first injection, second injection, and 9 days of oral Valgan, his vision improved to counting fingers 5 meter. And this was his latest follow-up. 3 months, at 3 months, his vision is now 6/9. He's on maintenance dose of Valgan. So the challenge is there are cases of recurrent acute retinal necrosis which have been reported, and there is no evidence of delayed recurrence of AN. And what is said is that herpes AN is more likely to recur as compared to VZV AN, though recurrence is extremely rare. So we need to keep that in mind, and that is where the importance of CPC comes. I'm not saying HSV AN should recur, but if it recurs, you are warned as an ophthalmologist. So this was a case of HSV recurrent viral retinitis with acyclovir-induced nephrotoxicity. But since we knew it is an HSV viral retinitis, we could manage with alternative regime. Thank you very much.
Thank you, Dr. Rima. It's a wonderful clinical presentation mostly, but I want to ask JB sir, so his experience on the enucleated eyeball of a viral retinitis, what are the inference for those?
We have 2 eyes of acute retinal necrosis, and what we could see that there is a full thickness retinal necrosis occurs over there, and what happens is that there is a vasculitis involved. The vessels are inflamed. Surrounding there is acute inflammation was seen, or also I could see the endothelial cell proliferation, and there is a herpes virus that was due to herpes virus. We could find the inclusion bodies also in the herpes virus. So we couldn't do the electron microscopy. The electron microscopy was not working. Transmission electron microscopy we wanted to do. We couldn't do that one, but we could get that inclusion body.
Thank you, sir. Rima, do you see again a mixed infection, CMV versus HSV versus BJB when if you do primer for run primer for all the 3 PCR, sometimes all 3 are positive?
Yeah, we always run all the primers for all the viruses together, but I haven't found any coexistence as such.
Okay.
Thank you, Dr. Rima, for the wonderful talk. Our next speaker is Dr. Dipankar Das, who is the head of ocular pathology and uvea services at Sri Shankardev Netralaya. He's an avid researcher, publisher, and a brilliant pathologist. So he'll be speaking on clinical pathology of choroidal melanoma.
Good afternoon, everybody. So my presentation will be very basic. So we can ask question 10 minutes. I'll try to finish. I do not have any financial disclosure to make in this presentation. Now, case of number 1 is very interesting. 58-year Indian male from Northeast India. There's a dimness of vision in the right eye for 18 months, and there was diagnosis of neovascular glaucoma and retinal detachment in that eye from elsewhere. No other significant history, and there was no perception of light in the right eye. Left eye vision was okay. There's iris shows some neovascularization at certain quadrant. IOP was 43 mm of mercury. There's a dense cataract in the right eye. Fundus not visualized. This is B-scan ultrasound showing the anterior border of a mass in the vitreous with a high spike, then incremental decrease in the spikes. Okay, this negative kappa angle, which in the lower portion there was some excavation can be seen, and sonologist has opined that it's a choroidal melanoma. CT scan was done because patient was from economically poor patient. So we have done and we have seen the mass there, and other investigations were normal. So since there was a painful blind eye and secondary glaucoma, I was enucleated and different measurement was done for this. Transillumination defect shows a internal tumor, and cut section showed a brownish pigmented mass with exudaretinal detachment. This is the exudaretinal detachment, and this is a collar stud mass that we have seen. Now these are the stain which I like to address. When you get a one-half of the eyeball, you can explode this. For example, I have stained with fluorescent stain, whether I can catch those cells there. And these are the crush smear cytology that you have seen. Again, you see the crush smear cytology showing a pigmented cells in the gross specimen. Now, here you can see in the fluorescent, the epithelioid cells can be visible, which were later confirmed in histopathology. In permanent section after 3 days, the cornea was normal, angle was a bit closed here, and there was a choroidal melanoma with a pigmented cells. When we did in high power, it showed epithelioid as well as B cells, spindle cells. These are the, you can well appreciate some epithelioid cells here, and here there was a peripheral cystic degeneration was noted. Now pigment cells migration was seen in the sclera. This is very, very important why I am showing this. Now we see this is the exit of the vortex vein, and here the pigment cells are seen. So these are very important to see the vortex vein exist, and the cut end of the optic nerve was normal. This is basically important for retinoblastoma, but we even have to see in the eyeballs. And now here you see some spongiosperm appearance in the sclera around the tumor. We have done a Elsian blue stain which showed some deposit here, and trichome stain also showed some deposit there. And HMB 45 showed in ISC showed the pigmented cells, and KI index was 30 to 50%. So this was a biphasic epithelioid and spindle cell with HMB45Ki67 involvement. So choroidal melanoma associated with spongiform scleropathy that we have published this. Case 2 is again a very interesting. It is 70 years old Indian male with diminution vision of the left eye now, progressive in nature, and there's a lump in the back of the patient. Okay, we have seen this patient during the COVID time. So when the vision was poor in this case, and also the pressure was shoot up, and we thought that pressure was 28 mercury. There's a dense lenticular haze and perception of light in the left eye, and it was also enucleated. The measurement, etc., were done. And you see, oh, this slide came before. In B scan again, you can see with the there were collar stud apparent with excavation can be seen, and in CT scan also the lesion could be elicited. Now we see intense illumination. Here we could not get too much information, but in cut section there's a pigmented tumor with exudaretinal detachment. Portion of the lens was seen. Again you see this raw specimen, because other half we do not use for the purpose, and you take a small snip of the tumor and you can even see the epithelioid and cells like picture in this raw specimen. Normal cornea, normal iris, normal ciliary body. There was exudaretinal detachment in the vitreous cavity, and vitreous cavity showed pigmented tumor with epithelioid and spindle cells. Again, it is customary to do a optic nerve curtain examination, which was normal. So again, this is again a biphasic, both epithelioid and clear cell tumor with ciliary, part of the ciliary body thing. An important thing for the pathology is to group them into HGCC 8 staging, whether it was 2B and T2B was there, and histological grading was grade 2. So we can make a histological grading and HGCC typed in front of your thing when the specimen come for retinoblastoma and other thing, and you group and give the clinician the HGCC classification. That's very important. So both the tumor had a breakthrough Brooks membrane, that is a collar stud appearance in this case, and in first case we saw melanoma associated spongiform scleropathy, which is usually seen in 38% of cases, and there is a collagen degradation near the tumor. What is important in this publication and this case, we have not done a biochemical analysis in this case, and if you get those cases, if you can do in the future biochemical analysis, this gives a very important result for your pathological finding. To sum up the pathology of choroidal melanoma, so this is what Professor Shield has given for small melanoma, TFSOM UHD. This is very, very important. Usually thickness is more than 2 mm in melanoma. You find subretinal fluid. You get a symptom of flesh as an orange pigment. Remember, in melanoma you get an orange pigment, but in benign nevus you get drusen. Okay, ultrasound hollowness in benign, and major factors are more than 2 mm, orange pigment, it is lipofuscin pigment, and fluid. So in clinical case you get a B-scan ultrasound, and in histopathology same choroidal excavation and other thing can be representative. Now you see you get a specimen in like this. Always remember that educate formalin is there in the specimen, and what is important here is that marking of the vortex vein. This is very, very important, okay, and you have to see this thing there. And you see this is again a large melanoma, and you see base of the tumor and the anterior posterior diameter is very important, because what is there, you need to have small melanoma, medium-sized melanoma, large melanoma, and extra large melanoma according to COMS study. Now you see these are all being seen in the rapid fluorescein stain. These are the spindle cells and epithelioid cell. What is important is that sometimes a masquerading tumor can be in the vitreous cavity, and there is always a issue that no, you cannot catch up in the what you called in the smears cytology. Always clinician complain to the pathologist. Okay, you can make a number, including a what you called a fluorescent stain. If you see, if cells can come in the vitreous cavity, and in real time fluorescence can come in the vitreous cavity, even in the live patient also in the 90D, we can able to see one day this type of cells in the vitreous cavity. This is the epithelioid cell, already I have shown you. So different pathologies we have to document it, and see there is a spindle A, spindle B and epithelioid cell. Spindle A is a flattened cell with a enfolding of the nuclear membrane, and these are prognostically very good. Spindle B a bit plum shaped with a nucleus and nuclear, and epithelioid cells are much more plum cells, and they are less cohesive, and most important, you have a nucleus and nucleoli, and they are prognostically bad. These are the mixed melanoma. This already I have explained this, and this is a epithelioid melanoma, and sometimes HMB45 can be done, or Melane or MITF can be done in those. What are the prognostic factors? Very, very important. So chromosome 3, chromosome 8, and chromosome 6, the warts as well as the favorable prognosis. Size of the tumor I have already told, small, medium, large, and extra large. More the larger tumor, bad the prognosis. Extrascleral extension have bad prognosis. Anterior located tumor are worse prognosis because they are hidden under the iris and you cannot see them. And lymphocytic infiltration and local tumor recurrence are important. Now, close vascular, Raman Font et al. Had studied the vascular pattern, 9 patterns they had found, and this is a closed vascular pattern that we have seen. HMB45, how beautifully it has stained the cut end of the optic nerve. You see, this melanoma cell has stained in this. Vortex when invasion, very important. You can do a innovative imaging as well as histopathology in this. And this is the choroidal melanoma seeds Ubaid and myself and my other co-author has published in a peer-reviewed journal. And to sum up, choroidal melanoma have varied presentation. 2 atypical cases I have shown you, and these are my selected reference. I like to thank Dr. Hemlata Deka, our medical retina HOD, oculoplasty department, Dr. Kasturi, Dr. Ganesh, ocular pathology laboratory, Dr. Bidhan, and Mr. Apurvo. Thank you for patient hearing.
Thank you, sir, for the wonderful talk and beautiful documentation of all the cases, sir. Any questions to Dr. Dipankar?
Yeah. Sudh. Yeah, prognostic importance of this case, no? The pigmented cells were there around the spongiform thing. So that was the thing in the this is the sclera, spongiform appearance. In some areas there were the pigmented cells. Whether there is a pigment migration occurs before this spongiform cell or after this spongiform change, we do not know. But one thing is that sometimes even in the retinoblastoma seeds, no, there are pigmentation happens, okay? And this is actually we don't know if you can make a study out of it of the pigmented cells in the tumor, okay? Whether they are a prognostic important, you can find yourself. So I think some sort of migration, they are signaling that there may be going to spread outward.
Okay, thank you, sir.
Now I like to invite Dr. Ubaidur Rahman. He is the consultant at Shroff Eye Institute, New Delhi. He did his fellowship in oculoplasty, ophthalmic pathology, and ocular tumor at Shankardev Netralaya, Guwahati. Now he had numerous publication to his credit, and he had also a publication in what you call IgG4 related disease. Dr. Ubaid.
Thank you, sir, for including me in this course, and it's an honor to share the stage with such esteemed personalities. So, good afternoon, everyone. I'll be talking about idiopathic orbital inflammatory disease. The orbit is a Pandora's box because you don't know what you're going to get inside the orbit. And when talking about orbital inflammations can either be specific, which have a definite local or a systemic cause, or orbital inflammation can be non-specific, which is going to be covered here, which is also known as idiopathic orbital inflammation or orbital pseudotumor. So, idiopathic orbital inflammation is a benign, non-infective, inflammatory condition of the orbit which does not have any local or systemic cause identifiable. It is also known previously as pseudotumor, and it is the third most common orbital disease. So, anyone dealing with the orbit and even the pathologist must be aware of this entity. And the prevalence is most common in third to fifth decade. The disease is mostly unilateral but can also be bilateral. These are the 5 signs of inflammation that all of us have studied. So, keeping this in mind, the presenting features of IOID can be varied, ranging from orbital pain to a mass, diplopia, proptosis, limitation of motility. Then, if the posterior orbit is affected, decrease in vision, neuropathy, and inflammation can be acute or subacute, but it is also important to understand and remember that inflammation is also chronic. This is the classification of IOID based on the onset, and according to the structures that might be affected in IOID, it can be classified as anterior, posterior, apical or diffuse IOID. So when the lacrimal gland is affected, it is dacryoadenitis. Sometimes isolated muscles or multiple muscles can be affected, known as myositis. Then if the sclera is affected, it is scleritis. Then the optic nerve or the optic nerve sheath can be affected in perineuritis. There can be isolated orbital masses. There can be apical involvement, or it can be a diffuse IOID. So radiologically, these are the different features of IOID. I'm going to move forward from here. This is the histopathological classification of IOID. It can either be a classic chronic inflammation, granulomatous variety, or sclerosing variety, which has fibrosis and sclerosis. So we're going to go through some interesting and atypical cases of idiopathic orbital inflammation. This is a 47-year-old female who has a right eye swelling and fullness, which can be seen. Has history of pain, but there is no systemic history. And if you see, the duration is 6 months. So as I said, it is important to remember that inflammation can be chronic also. So on imaging, she has bilateral enlargement, homogeneous enlargement of the lacrimal gland, right side more than left side. And when biopsy was performed from the right orbital lobe, it was seen that there was chronic non-specific inflammation, some interlobular fibrosis, and positivity for IgG4 cells. So she underwent extensive rheumatological workup, all of which turned out negative even for IgG4. And after receiving 3 pulse doses of steroids, you can see the proptosis has gone down, the ptosis has improved, and she's on regular follow-up now. This is another interesting case of a 9-year-old female who presented with right eye cataract with a retrolental membrane, which was painful, and there was a dubious history of trauma. There was no other important relevant history. And when B scan was performed, the B scan was normal, but if you look at the ultrasound biomicroscopy, you can see infiltration of the iris and the ciliary body and a mass lesion sitting there. So in view of the mass lesion, further imaging was performed. The MRI is not very representative here, but there was a ciliary body swelling, and a probable diagnosis of medulloepithelioma was kept, and the eye was enucleated. But on the enucleated eyeball specimen, surprisingly, a dense inflammatory infiltrate was noted, which was involving the iris as well as ciliary body, with a lot of lymphocytes and plasma cells. So multiple diagnoses were kept in mind. IgG4 was again considered along with xanthogranuloma. but the serum and tissue IgG4 levels were low and markers for histiocytes were negative. There were no macrophages also to support xanthogranuloma. So a final diagnosis of intraocular IOID was made and no further treatment was done for this patient. This young male presented with swelling and fullness in the left upper eyelid, which can be seen, which progressively increased in size. And probable diagnosis of epidermoid cyst was kept in mind. This lesion was debulked, but on histopathology, again, a very rich lymphocytic infiltrate was noted. And IHC panel showed a polyclonal nature of the infiltrate. This patient received systemic steroid and there was complete resolution. This is another interesting case of a 9-year-old girl who had acute painful diplopia. And if you see, her elevation is restricted in the right eye, but there are no signs of inflammation here. On imaging, there was a diffuse enlargement of the inferior rectus, which can be seen. It was irregular and the tendon was also thickened. This patient again received systemic steroids and you can see the diplopia improved and the elevation has also improved here. Another case of a child who presented with reduced vision, and on the fundus examination there was disc edema. On the external photo you can see there is congestion, ptosis and a mild proptosis also. The eye movements were very painful. Imaging revealed some sort of thickening near the sclera which can be seen there and along the optic nerve. This patient again received systemic steroids and improved with systemic steroids. So a probable diagnosis of apical neuritis was made. This gentleman presented with a painful proptosis in the left eye. You can see there is skin puckering there inferiorly in the left eye, and there is limitation of extraocular movement. Unfortunately, I don't have imaging for this patient, but a biopsy was performed from the swelling in the inferior eyelid, and a paucicellular infiltrate with a lot of extensive fibrosis came out, which is characteristic for sclerosing NSOID. This patient again received steroids and did well. So the pathogenesis of IOID is still unknown mainly. There are two major theories. One is the viral infection theory and one is the autoimmune theory. And there is evidence in literature to support that. But histopathology is important, and the decision whether or not to do the biopsy depends on the site of the presentation and the imaging findings. And histopathology will invariably reveal chronic inflammation with lymphocytes, plasma cells, eosinophils, and varying degrees of fibrosis. Sometimes granulation or IgG4 positive cells may be noted. But the most important thing is that the proliferation is always polyclonal. So when dealing with the orbital IOIDs, there are some important differential diagnoses that need to be kept in mind. An important one is lymphoma. So clinically, lymphoma is going to be painless, usually presenting in the older age group, and on imaging you will see molding of the swelling around the globe. And when you do histopathology, monoclonal proliferation will be seen. Then thyroid eye disease is another very close differential for IOID. But unlike IOID, thyroid usually has a chronic presentation, and the patient may have history of thyroid disorder also. There will be lid signs, external signs. Apart from that, when you perform imaging, unlike IOID, there will be tendon sparing muscle enlargement, which is known as the Coca-Cola sign. And you'll also see orbital fat enlargement. Orbital cellulitis is one more important differential diagnosis, which will present with pain, but there will be systemic symptoms also, such as fever. You might identify a source of infection, especially the sinuses, which are the most common route of spread to the orbit. Then in children, differential diagnosis of dermoid rhabdomyosarcoma and lymphangioma. These are the three things that need to be kept in mind. Again, radiology and histopathology will guide us towards the diagnosis. For management of IOID, systemic steroids are the first line of management. They have a very fast onset, give a very good response. But it is important to remember that IOID may recur after steroid withdrawal, and the patient need to be counseled about that. Immunosuppressants form the second line of management. These are steroid sparing, and patients who might not be responding very well to steroids may be started on immunosuppressants. Orbital radiotherapy is another management option in patients who are refractory or intolerant to steroids. 20 gray is the usual dose which is given over 10 days to patients, and a good response is seen in the short term, but radiotherapy of course has complications in the long term. So the management line, if you see typical features of IOID which have been discussed, if it's the first episode unilateral disease without any systemic involvement, the patient can be given a trial of low dose steroids. Usually the prognosis is good in such patients and recurrence remains unlikely. But if disease is bilateral or recurrent or there is apical involvement, the patient definitely needs a high dose of steroids, may also need immunosuppressants. And such patients need to be investigated systemically because there are a lot of differential diagnoses for this condition, and a close follow-up should be maintained. Biopsy can be performed for anterior lesions. And when the patient has atypical presentations, such as the last case we saw, and patients having sclerosing NSOID, again biopsy will confirm the diagnosis and the specific disease needs to be treated. So the prognosis is generally good for IOID. It is considered a self-limiting condition by many people. And the primary goal in IOID remains control of inflammation in the acute stage and avoiding any long-term complications. And steroids can be started for the acute phase, followed by slow tapering. Usually a good prognosis is seen in this condition, but the patient still needs to be counseled for recurrences, especially when multiple muscles are involved. So thank you. That was
Thank you, Dr. Ubaid, for a wonderful presentation. Any short question to Ubaid? We have 3 minutes time. Any question? Bhagyashari Madam, Soumya, any question to Ubaid? Can you speak on the mic?
So we often encounter IOID as granulomatous inflammation. Will that be just a diagnosis of exclusion of all the infectious diseases, or we have to find something else in that?
So IOID is a diagnosis of exclusion because you have to rule out all the mimicking conditions. Granulomatous inflammation usually does not fall under IOID because there are a different set of conditions such as sarcoidosis or maybe tuberculosis, which will present with granulomatous inflammation. So if you find granulomatous inflammation, it is better to investigate the patient systemically. Also, it will depend on what are the imaging features, what is the clinical presentation of the patient.
Well, I like to add, if you see a diagnosis IOID for pathologists, only a GMS, GIS, tissue gram stain, and AFB must be done, okay, to tell that it is a IOID. And the CD3, CD20 or CD138 for plasma cells and the IgG4. So this question is very relevant. As a pathologist, she's asking on the pathologist point of view. Here we have to do GMS for fungus, we have to do tissue gram stain, and we have to do a AFB stain to tell that it is a IOID. Thank you, Soumya. So if we do not have any questions, then thank you very much. I like to thank everybody here who came, all pathologists, Madam, Soumya, Shruti, everyone. I like to thank Dr. Somashila, Rima, Ubaid, JB sir. He has gone for another session there. And thank you so much for that. We can have a group photo, please.